Welcome everybody. Congratulations for getting here. Train strikes and vicissitudes. Yeah, things don't always work perfectly smoothly these days, but I think we've got a good component here, and I think we have quite a few people online, probably more people online because of the industrial action. So we're going to have a great meeting about palliative care and about cancer management, cancer survivors. I'm actually a cancer survivor myself because being a prostate specialist, I decided to check my PSA, prostate specific antigen. Some people call it a promoter of stress and anxiety. So I got anxious and stressed, and in the end I ended up in the London clinic and where I parted company with my prostate about 12 years ago now, and here I am. A cancer survivor. So I'm really interested in today's meeting. And what we want is some really interesting talks. We've got some great speakers, but we'd love some audience interaction with microphones at the end to ask questions, because there are lots of issues in palliative care. We're just talking about them outside. Workforce issues, funding issues, the question of the term cancer implies a dread disease that you're going to die from, chemotherapy, all your hair will fall out and so on. But in my case and many other cases, you have it, get it sorted and move on, but you're still a cancer survivor. So there's lots of issues that we can talk about. And I see Lorraine, my good friend Lorraine there, and lots of issues about not just survivorship, but the issues caused by, for example, prostate surgery that need to be managed and controlled. So there's so much we can talk about. So we're going to start off with Andrew Davies, who was a palliative care consultant in Guildford in Surrey. He decamped 3 years ago to the wonderful city of Dublin, and now he was telling me lives in a gorgeous house overlooking the ocean and has a glorious life there, working between Trinity College Dublin and UCD, yeah. And that's interesting because those two organisations, you see, it was a bit like Chelsea and Arsenal. They're trying to play for both Chelsea and Arsenal. That ain't going to work. But he's managed to pull it off, really, and you can perhaps tell us a bit about how he managed to do that. So if you come on, then Richard Langford, now finally he's got his microphone on, left it to the very last minute. But Andrew first, and then I'll get up and tell you a little bit about Richard, who I've known for many, many years. You're on.
Thank you.
Just remember we've got people online watching you. Okay?
Yeah, so thank you for the introduction. Thank you for the invitation. So yeah, it's a bit unusual for me to be first on, because usually they stick palliative care right at the end. And I mean, this is a meeting about cancer survivorship, and you might say, well, what's that got to do with palliative care? And I will try and explain that. But what I'm going to do to start off with is try and set the scene. So what are we actually talking about when we talk about cancer survivors, cancer survivorship? What are the issues, and how can health services support the different cohorts of cancer survivors, and how in particular can palliative care help? So I have talked about this slide a lot with colleagues and my family. Oh, it's not going forward. Can you advance this? Yeah. Okay, so I was advised not to put this slide up because nobody would understand this slide. Because I'm looking at the audience, you're all probably too young to recognize who these two characters are. Okay, I'm not going to ask. So do any of you remember Trumpton? Oh, some people do, right? Okay, so this is the mayor of Trumpton. He didn't have a name, he was just called the mayor. And this is Mr. Clamp, who was the greengrocer. Okay? Just stay with me. Okay? Okay, now I think more of you will know who this guy is. I don't mean the actor. Who's this character? Yeah, Private Jones. Okay, but can you remember, so this is from Dad's Army, okay, the Home Guard. Can you remember what Private Jones's day job was? He was the butcher, yes, in Warmington-on-Sea. There's his van. So you might say, right, okay, what has Mr. Clamp, the greengrocer from Trumpton, and Private Jones, the butcher from Warmington-on-Sea, got to do with anything? Well, this is specifically for Dr. Patel, who's sitting in the audience. Okay, a famous palliative care physician regularly says, if you want a cauliflower, you need to go to a greengrocer, Mr. Clamp. If you want a lamb chop, you need to go to a butcher, okay, Private Jones. And this is a theme I'm going to be coming back to, okay? If you have a specific problem, and Richard's going to talk about pain, okay, yes, you can go and see a non-specialist. You can go and see your GP. You can go and see your oncologist, you know, your urologist, whatever. But if you really want your pain sorting out, then you need to go and see a pain specialist, okay? And this is particularly true for cancer survivors and the sort of issues that cancer survivors experience. Now, some of those issues can be easily dealt with by general practitioners and other healthcare professionals, but a lot of those problems need very specialist care. Okay, so this is what I'm going to briefly talk about, and it is going to be brief, over the next 18 or so minutes. Who is a cancer survivor? Okay, a little bit about what palliative care is, talk a bit about the unmet needs of cancer survivors and how my colleagues may or may not be able to help different groups of cancer survivors. And then what we need to do going forward, because it's clear that we need to do something. As Richard will talk about, it's quite frightening. I mean, in some ways it's great news. Okay, treatment for cancer has improved dramatically. And the number of people who are living with cancer and living beyond cancer, the numbers are increasing almost exponentially, which is great news. But with that improvement in survival, there is a lot of morbidity. And we need to address that. And we need to address it now because the numbers are high now and the numbers are just going to continue to increase. Okay, so who's a cancer survivor? This is very, very controversial, okay? So this is the definition from the National Cancer Institute in the USA. So the National Cancer Institute is a bit like the NHS, the cancer arm of the NHS in the US. This is the definition. And so essentially, a cancer survivor is anybody who has had cancer, okay, or still has cancer. So it doesn't talk about finishing treatment and not having any cancer left, finish treatment after a certain period of time still being cancer-free and surviving. So it's not a very helpful definition when you're trying to discuss how the problems cancer survivors may have and how you manage them. And this definition has been used either in whole or slightly adapted by lots of other important organizations, not just in the US, but in Europe and beyond. So it's a bit like saying, I want to buy a car. Okay, what's the car do you want? I want a red one. Well, that's a red car. Nice if you want, you know, an old-style Mini and whatever. A bit temperamental, needs a bit of work doing to it on a regular basis. Or you can have a brand new electric Mini. Okay, much bigger, much faster, much more reliable, green and friendly. Or you can have an Aston Martin Vantage S. They're all red cars. And that's, so saying you want a red car is not very helpful to the salesman. You need to be more specific. And that's what we need to do when we're talking about cancer survivors. Okay? Being a cancer survivor, according to the NCI definition, means that just at some stage you had cancer. It doesn't tell you whether you still got cancer, doesn't tell you whether your prognosis is normal for somebody of your age, or whether it's short. It doesn't tell you what your unmet needs are. And I think in the audience, lots of us would have particular views about which one of these three cars we'd want. Okay, so this is where I work, or one of the places I work. Okay, this is Our Lady's Hospice in House Cross in Dublin. So the whole of this area here is the actual hospice building. This is the Education and Research Centre, which is where my academic department is based. And this is, we have a rehabilitation unit and a rheumatology unit over here. And this is various other bits of the hospice. So according to the NCI definition, all of the patients in these wards, all the patients I look after are cancer survivors. Okay, these are people who have advanced disease, progressive disease, with a prognosis of weeks to months. Okay, so labeling them the same as somebody who's had surgery, curative surgery for prostate cancer, label them in the same group of people is not helpful. Okay, and if you look at a lot of research that's out there in the literature, they say we looked at 120 people, cancer survivors, but it doesn't tell you what those are. So when you're trying to extrapolate how you manage a problem and you look at the data, you don't know whether these are the same patients you're seeing in front of you or a completely different group. So it's really important that we have a better understanding of the different cohorts of patients and what the particular needs of those cohorts are. Because if we're going to manage these patients properly, or these people properly, not patients, because lots of them aren't patients anymore, we need to know where they are in their journey and what we need to be looking out for. So if somebody's got pain, is this pain because of treatment they had in the past, or is this pain because maybe they've got a recurrence of their cancer? Okay, so we need to better define it. And this is one classification, for want of a better word, which is more useful. Okay, so splitting people up into patients living with cancer, okay, living through cancer, so patients who've finished treatment, and it's a bit unclear about what their long-term prognosis would be, and patients living beyond cancer. And I'm going to focus on this latter group because in palliative care, as I'll show you in a minute, we see a lot of these patients in any case if you work in a hospital, because these people have acute symptoms in particular that actually we have the skills to manage. Okay, what is palliative care? Okay, this is probably what you think about when you hear about palliative care. And this is a big problem as well. Okay, when we get asked to see in the cancer centre patients who've just been diagnosed with cancer, who are likely to, if not be cured of their cancer, certainly be a long-term survivor, and the oncologists say, we're going to refer you to the palliative care team to come and sort out your pain. People go, whoa, I do not want to be seen by the palliative care team. I thought you said everything was all right. I thought you said if I have treatment, I'm going to be fine. So there's a problem about labels. Just like there's a problem about labeling people as cancer survivors, there's a problem about labeling palliative care. This is the definition of palliative care. It's a bit like the definition of a cancer survivor. Okay, it's not very helpful. Okay, this is what we do. Okay, and I'll show you in a minute some of the unmet needs of cancer survivors from a big study in the US. And on the surface of it, lots of the problems that cancer survivors report are very similar to the things that we do, except we do it in a completely different group of people. So Richard's going to talk about the management of cancer pain, chronic pain. Okay? That is very different from the pain that I manage. I manage acute pain. I'm the biggest drug dealer in the south of Dublin, okay? I dish out, opioids like they're going out of fashion, but for a specific group of patients. Okay, and for people who have chronic pain, opioids don't work that well. Drugs don't work that well. Okay, they need a multimodal intervention, and I'm not going to talk any more about it. Okay, but just because we as a group are good at managing these problems in patients with advanced disease does not mean we will be good at managing it in all patients. We're good at managing cancer patients. We're not good at managing people with even advanced non-malignant disease, heart failure, COPD, blah, 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 blah. And we have to realize that, because there is a problem within our specialty that we're nice people, okay? We want to help, okay? But you can't help somebody if you don't know what you're doing, okay? And being nice and being useless is not a good combination. I mean, it's better than being horrible and being useless, but it's not a great combination. And this is part of, this is old. I say this is old. This is from a Lancet oncology paper from a couple of years ago. This is the model of palliative care. It's absolute nonsense, okay? It's because we see people at all stages of their disease. As I said, I see people that are going to be cured, but they've got pain, okay? So we can sort out their pain while the oncologists are curing them of their cancer, if it's appropriate. Okay, so that's, this is nonsense. So we will see people, okay, at any stage of their illness until they stop having treatment, if it's appropriate. It's after they finish their treatment that there's this issue. Okay, so what are the unmet needs? Okay, we could spend all day talking about the unmet needs. And I'm not going to go through this slide, it's really busy. This is a survey done in the US, okay, by ASCO, the American Society of Clinical Oncology. And it asked cancer survivors, and by that, this is mainly people who have finished treatment and whose disease is thought to be either cured or certainly the chances of it coming back are relatively small. And you can see the percentages here. And there's a whole range, there's another slide as well, okay? Whole range of problems. Now, right at the beginning, right at the top rather, is the physical stuff. That's the stuff I do on a day-to-day basis, okay? And that's the biggest issue. But look at the problems, okay? I don't do sexual dysfunction. I don't know what to do, okay? Maybe some of the nurses I work with do. But, that's not my thing. Diet, exercise, and rest. Do I know about diet, exercise, and rest? That was my wife laughing, by the way. I can tell you'll laugh. So yeah, I mean, we do a lot of physical, management of physical problems, okay? But they're different ones to what these people have. So instead of saying, yeah, come to my clinic, I'll sort you out, okay, and he's saying, actually, I'm not quite sure I know what to do, okay? But the question is, who does know what to do? And that's another problem, is chronic pain, yeah, we've got an idea how to manage people with chronic pain. Other symptoms that are chronic, we haven't got a Scooby-Doo, okay? And so we need to think about, and I'll talk about this in a minute, developing specific services for these people. We need to do research. Just because something works in people with early cancer doesn't mean it's going to work in somebody with advanced cancer. And that you go down this list, and we're going to talk a little bit later about the psychological problems. Okay, fear of recurrence. Well, I don't know how to deal with that. I mean, I see a lot of people, who are anxious, depressed because they've got advanced disease and they're dying, have lots of concerns about, what's going to happen after they die. See lots of people who are at high risk of bereavement. Okay, but the sort of issues that these people are exhibiting are completely different issues. I can't reassure you cancer's not going to come back. I'm not an oncologist. Okay, I mean, I could tell you, oh, don't worry, it's not going to come back, but that's not what you want to hear. So the problems are different. The solutions need to be different. Okay, all of this stuff as well. The problems need to be addressed by people who know what they're doing. Okay, and there's this very influential report. Institute of Medicine in the States produced this report on cancer survivorship, and this really, I think, stirred up the whole cancer survivorship debate movement in the US. And it talked about the 4 essential components of survivorship care. These are the things that need to happen for these people who come to the end of their treatment. Okay, I mean, the surveillance stuff, the prevention of new tumors. I don't know how to do that. I don't have access to those services. These are all really important things, okay? You know, this stuff about intervention for the consequences of cancer, I can do some of that stuff, but not all of it. And actually, at the moment, certainly in the UK and Ireland, and in most of the world, there are no comprehensive services for these patients. Okay, it's very hit and miss. So, having said we can't help, maybe we can. Okay. So I want to tell you about some stuff we're doing, which actually might be relevant. This is a cheap plug for my research program. And if there are any multi-millionaires in the audience, okay, I can give you my email later. We have limited capacity. We are struggling to see all the patients who have advanced disease, all the patients who have advanced cancer and have a limited prognosis, let alone all the people who have advanced COPD, heart failure, et cetera, and now people want us to see dementia patients. I mean, again, we don't know how to manage dementia patients. You know, the behavioral issues and whatever. We don't know how to do that. And now we'll take on all these cancer survivors, but we don't know how to do it. So we don't have the capacity. We don't have the knowledge or the experience. And actually, very few people do have the knowledge and experience. And actually, there's a huge gap in the knowledge. So we need to understand that, and we need to do some research and find out what is the best way to manage this problem in somebody who's cured of cancer. Okay. And the other thing is, most of my colleagues, they went into palliative care because they enjoyed palliative care. Okay. You know, this might sound a bit, you know, gory, but, you know, they like looking after that group of patients. They don't want to look after cancer survivors. They're quite happy doing what they want. It's a bit like, you know, they don't want to look after, you know, people with dementia. If they don't wanted that, they'd become a geriatrician or a psychogeriatrician or whatever. So there's a lack of interest from a large number of my colleagues to expand palliative care beyond that. Right, okay, so I said there may be some things we can do. So this is one of our research interests. Okay, circadian rhythm disorders. So in the morning, okay, the sun comes up, hopefully. It doesn't always in Ireland, but, okay, and we wake up, okay? And we get peaks in cortisol, okay, and our melatonin level falls and whatever. And we're awake. And then as the day goes on and it gets dark again, the cortisol levels fall off and the melatonin levels go up. And it's a cycle. And every living organism has a circadian rhythm, okay? But patients who have cancer or have had cancer, often their circadian rhythms are out of sync, okay? And so this is an actigraphy trace. So this is a patient who's wearing a watch on their wrist and it measures their activity. And the grey bars are sort of the time that they're in bed. So most of the time when you're in bed, you should be asleep and you should be resting. So there should be very little activity during these periods. And most of your activity should be during the daytime when you're up and about. That's what happens. Okay. When you get cancer, okay, these rhythms get disturbed. So you can see that there's very little difference between the daytime and the nighttime in this person. Okay, so they're restless at night. They're not sleeping. They're getting up. They're moving around. Okay, so, okay, they're getting disturbed sleep. So what? We give them some sleeping tablets. Well, it's not that simple. Because those people who've got these altered rhythms, okay, have worse symptoms generally, but specifically fatigue, sleep disturbance, psychological problems, depression. There's a symptom cluster. And this happens in patients newly diagnosed, patients on treatment, patients with advanced disease, and cancer survivors. It's sort of, it's probably one of the only things that sort of follows patients all the way through. This is a severe cause of morbidity. Okay? Okay. It impacts on their quality of life. It also impacts on their prognosis. People who don't sleep well, we know this from the general population, die earlier. Okay? If you sleep too little and if you sleep too much, your survival, okay, is worse. So going back, these are the two traces I showed you earlier. This is from a really important paper rather. So patient 1, okay, and patient 2, okay, are, I think they are, yeah, they're 35-year-old colorectal cancer patients having chemotherapy. So 35-year-olds, okay, relatively fit and healthy. I mean, I know they've got metastatic cancer, okay, but equivalent in all other ways, where the cancer is, their symptoms, their performance status, how active they are, etc., etc. Okay, the only obvious difference between the two is this difference in their rhythms. Okay? Okay, so patient 1 survived for 37.5 months. Patient 2 survived for 16.6 months. Okay? So the question is, can you change that into that? Okay? Because this is a, particularly in cancer survivors, okay? Because if they don't have any active cancer that's driving this process, why can't we get them back? You know, the bits of the brain that are involved in these circadian rhythms are essentially normal, unless they've had a brain tumor or, you know, brain surgery or radiotherapy. So, can we do something about it? And that's what we're doing in Dublin. Okay, so there are lots of things that can affect these rhythms. So people with poor symptom control. So before you do anything, if they've got pain or they've got other symptoms, you need to sort them out. Okay, trying to get their sleep pattern better. So cognitive behavioral therapy, including things like sleep hygiene, sleep restriction, stimulus control. So this is really difficult to get patients to do, but you say to them, right, you have to get up the same time every morning. Let's say 7 o'clock in the morning. It doesn't matter what time you go to bed. It doesn't matter how bad your sleep is. Okay, it doesn't matter if you fell asleep at 6 o'clock in the morning, you get up at 7. You have to retrain your body, okay, that nighttime is sleep time. Okay? You don't go to bed till you're asleep. You don't go and sit in your bed and read a book or watch telly for an hour or so before you plan to go to sleep. If you get into bed and you're not asleep within 15 minutes, you get up and you go back downstairs and do whatever. You know, you don't drink alcohol, you don't drink caffeine, you don't smoke, blah, 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 blah. Okay? Bright light therapy. Okay? So in the morning, okay, when you get up, particularly in winter, you've got to put the lights on. No good creeping around in the dark. Okay, you have to put the lights on. You have to tell your brain it's daytime. Okay, and the way you do that is light going through the eye, okay, and stimulating the bit of brain behind the eyes. Okay, and what you can do is to supplement that is have literally a bright light. Thing you can buy them in boots. Okay, sit on your desk or on your table, bright light, half an hour a day. Okay, just reinforces the fact it's daytime. It's time to be awake. Okay, exercise. Doesn't have to be, don't have to go down the gym. It's just more exercise, walking. Walking is as good as anything. And food, okay? You eat during the daytime, okay? You don't eat in the evening. I mean, you have your early evening food. You don't snack, okay? Because, cavemen, they didn't have fridges, okay? And so go to the, 10 o'clock at night, get the munchies, go to the fridge, get whatever out of the fridge, okay? Cavemen only ate during the daytime when they went out to pick the berries or, kill whatever was roaming around. So there's very simple things you can do. And we're doing this in patients who still are under having anti-cancer treatment and seeing that we can reverse those circadian rhythms. and their symptoms are getting better. Now, we can't prove yet that it has any effect on their survival, but this is a problem that follows people through. This is a big cause of morbidity in those people who've completed treatment, long-term survivors. So we can do something because actually we know about this problem, and it's the same problem in all of these groups of patients, and we can extrapolate because all of these things can be done in people with advanced cancer, people with early cancer, people with no cancer. So we can help, but not with everybody. So what needs to happen going forward? Okay. So going back to the old analogy, okay, greengrocer, butcher. Okay, we have a whole group of patients, and Richard will expand on the numbers, okay, who need help, okay? So, you know what's happened to, over the years. There's less specialist shops, okay? We have supermarkets now, and we have Tesco, okay? That, feeds the masses, provides them with the meat and the vegetables. And then we have Waitrose, okay? For slightly, different clientele, slightly different products, okay? Because everybody's different. For lots of people, maybe the Tesco's option is fine, but for some people, the Waitrose option is what you really need, okay? But some people need to go to a greengrocer because they need something that you can't find in a supermarket, something really specialized. And some people need something really, really specialized, okay, that you can only get in a market stall in Tooting Market, okay? And that's the issue, okay, that cancer survivors, even people living beyond cancer, people who've finished their treatment, who we think their cancer's gone and it's going to come back, they're a heterogeneous group, okay? There's not a one-size-fits-all to make these people, to sort out these people's problems, okay? Yes, we need some generic services that will deal with the common problems, okay? But we need the super specialists as well. For the people who've got chronic diarrhea, for instance, following pelvic surgery, pelvic radiotherapy, okay? They don't need to be put on some Imodium, okay, to try and, dry them up, because that doesn't work. Okay, they need to see a gastroenterologist who's got all the kit, who knows what they're doing. Okay, it doesn't matter. And that's it. Thank you very much.
Thanks. Lots of issues there that we can discuss. My next speaker is the super specialist that Andrew's just... So Richard Langford's a pain specialist who leads the pain service at the London Clinic, founding director of the Pain and Anaesthesia Research Group for 25 years at Barts, founded in 1123, if I remember, and counsel of the European Pain Association. So, Richard, tell us about pain and palliative care.
Thank you. Marvellous. And the reason I wasn't mic'd up is that I've learned by now that you don't go to the loo with your mic on, so that's why I didn't put it on till I got back. Thank you very much indeed to the organisers and the clinic and the RSM for the invitation. And thank you for the introduction, Roger. As you've seen, I'm going to be talking about pain management in relation specifically to cancer survivors. And I'm very much, like Andrew, going to concentrate on those that are expected to live a long period of time. Now, of course, that is crystal ball gazing, but for the purposes of the arguments, as you will see, we need to differentiate folk from those that are going through an acute phase of their illness or a short-lived, sadly short-lived phase, and differentiate the ones who are going to live a long time. Because what we're talking about here is choosing and selecting the modalities that will best suit them and are safe for long-term therapy. And as you will no doubt know, it's not clicking again. Yep, now it's working. So, skating over my various declarations, I'm going to be covering briefly prevalence and etiology of chronic pain in cancer survivors. Now, as we've already heard, there is a huge variety and often the approaches have to be very specific. So I'm going to give a taste of lots of different aspects that we may have to deal with. Some of the treatment options and guidelines, unmet needs, as Andrew's already alluded to. And I'm going to be looking at just some selected aspects of pain management, because after all, we just got 20 or so minutes. So the cancer survivorship setting, as we've seen, is one truly a triumph of medicine, modern medicine. And we need to celebrate that. But a disease that was terminal is now a chronic long-term illness, or not even a disease at all, if it's been essentially eradicated, and if one can get over the mental health issues and all the other things Andrew talked about. There are huge numbers coming along, huge rise in survival rates. CRUK state that half of the people diagnosed with cancer in Britain will live at least 10 years. The expectation in the US is of 26 million new cancer survivors by 2040. Huge, huge numbers. And of course, as we know, cancers are recurring strangely and not fully explained at younger and younger ages. So lots of theories, but we won't go into that now. But it means the survivorship could well be decades, hopefully decades. So we also recognize that, as Andrew said, it can come at a cost. So we celebrate the survival, but we have to try and deliver care and make the quality of life as good as possible for those folks that have happily survived. And they may well suffer various physical and psychosocial effects and have all of the concerns that Andrew listed in that slide of his. One of those adverse effects, of course, is pain, from tissue damaged by the tumour itself or by various cancer treatment modalities, and they are often the commoner culprits, in fact. So I'm going to go into these in detail. I won't read them off now, but we're going to sort of run through them a slide or two on each one. So prevalence of chronic pain in those many, many cancer survivors that we see now, various studies, lots of different numbers around, but you get an idea of the range. So let's look at the number of cancer survivors of that 4,500 who, in the first bullet point, who had pain that limited daily life and work activities, so problematic pain, 16.1%. Now that doesn't mean it's only due to the cancer, it could be due to their many other morbidities that are around out there. And the prevalence of chronic pain in the population is also quite high, not quite as high as that in terms of problematic pain. So if we look at the next one, we'll see that in the very large CDC study from the States, from 18 American states, 9.5% reported current pain related to cancer or cancer treatment. And female survivors had more pain than male survivors. And of course, there are various factors that may contribute to the pain, but clearly the type and state of the disease and the type of anti-cancer treatments will play into that. In the UK, the Cancer Quality of Life survey by NHS England identified pain, stroke, discomfort as one of the main things that people responded to in their somewhat crude, but the EQ5D type sort of report. So you see there that pain and discomfort scored highest in terms of a positive response as to whether you have any pain or discomfort. The etiology I've alluded to a little bit already, so the tumor-related tissue damage itself can be all types of really the spectrum of pain that we know. Chemotherapy, of course, causes painful peripheral neuropathy that I'm going to deal with in more detail shortly. But you can also get neuropathies as a result of graft versus host disease, monoclonal antibodies, etc. Radiotherapy can damage both nerves, of course, if you're close to a plexus, like the brachial plexus in breast, for example, or it could be bowel, for example, causing visceral pain that is damaged. We'll come to that as well shortly. Surgery I'm going to deal with across a few slides because it's much more prevalent than many people realize. And of course, there's some specific things. And I give an example of just one of them, which is the aromatase inhibitors. So let's start with a really big one, which is chemotherapy-induced peripheral neuropathy. Happily, not all of those neuropathies are painful, but equally, you don't really want sensory or motor loss, but particularly sensory loss, but it's even worse if you have severe pain with it. So it seems to be quite bad and quite prevalent around the time of the actual treatments. Of course, it varies from drug to drug, but it's surprising how many of them are implicated in causing neuropathies. And it's around an alarmingly high 60% at 3 months, but that then drops to around 30% by 6 months and even lower later on. And in the Dutch cancer registry, they found that about 9% of survivors had painful CIPN, chemotherapy-induced peripheral neuropathy, and non-painful was 22%. The clinical features, of course, are the absolutely classic glove and stocking effect. And that, of course, is because the long nerves are more susceptible to such damage. And therefore, the more distal the site, i.e. toes, feet, fingers, hands, so on, the more likely it is that you'll suffer the symptoms there. And hence the classic distribution. The other effects of the peripheral neuropathy, or rather the chemotherapy inducing it, are by and large due to a combination of things: neurodegeneration, loss of nerve fibers in the periphery, demyelination, and degeneration of the unmyelinated fibers, chemotherapy-related mitotoxicity, with interruption of the energy supply to the nerves, neuroimmune mechanisms, and various ion channel dysfunctions that can occur. So a whole mixture of mechanisms. Moving on to the aromatase inhibitors I mentioned as another systemic effect, if you like, as opposed to a focal effect. So arthralgia is the classic issue with that type of therapy. But there are ways around this. Occasionally, I'm going to actually touch on how we deal, or my colleagues deal with these things, because I'm not going to come back to them later. So here, for example, it's quite interesting. You can have a holiday from your aromatase inhibitor without seemingly affecting prognosis. So, and there have been 1 or 2 studies on this. Usually then the arthralgia subsides, and on the second exposure to the aromatase inhibitor, it doesn't necessarily come back or at the same level. So you can have a holiday. And equally, it's an arthralgia. So you can approach it in the same way as we approach other chronic musculoskeletal pains, with exercise and weight loss. And if it's also in, there are other implications of mental health issues, etc., you can deal with those, and CBT, cognitive behavioral therapy, those sorts of approaches, as well, of course, other methods of dealing with musculoskeletal pain like we do every day with simple analgesics and so on. Radiotherapy, I'm just going to touch on this very briefly. Obviously, it's radiation-induced neuronal injury with fibrosis or ischemia of the nerves, perhaps. And it can, of course, lead to sensory disturbance and quite severe neuropathic pain sometimes, and things like the brachial plexopathies and so on that can be ghastly. Abdominal visceral pain, incredibly complex, difficult to treat. There are hardly any really good studies on abdominal visceral pain of any cause. But of course, it's due to the fact that the gastric mucosa is so susceptible, the high turnover of the cells, so susceptible to the treatments. And it ultimately leads to fibrosis, potentially ischemia, problems with dysmotility and strictures and all the sorts of things that we meet in a proportion of patients, happily not too many, but a proportion of patients who have these issues. And as you've seen, it's around 10 to 15% of cases after radiotherapy will have some sort of issue if their cancer was in the pelvis, for example. There isn't, as I say, great evidence for the management, but it's basically multidisciplinary. Ideally, opioid-sparing approach is recommended. Now, I'm going to touch on surgery, and because this is quite a big one, it's something we may be able to do something about. So surgery, of course, remains a very important modality for the treatment of solid cancers. Chronic pain developing after surgery, CPSP, is now included in the latest 11th edition of the WHO ICD classification as one of the 7 types of chronic pain. And it's broadly defined, there's no absolutely tight definition, but it's broadly defined as being present for more than more than 2 to 3 months after the surgery. You can, of course, have spontaneous pain. There can be exquisite tenderness and hypersensitivity. Wearing clothes can be painful around the area of the scar. There can be abnormal sensations arising in and around the area of the surgery. And it's presumably due to a variety of traumas that the nerves suffer. They may be rendered ischemic by blood vessels being tied off, squashed, cut, various toxic things happened around the nerves in the wound area and so on. So a variety of causes, and certain procedures are more likely to cause it than to cause long-term pain than others. And I've stripped out from the big table that this started as the ones which are more commonly associated with or could well be cancer surgery. So abdominal amputation, craniotomy, mastectomy, melanoma resection, thoracotomy. And you can see the numbers on the right are the percentages of patients who still have pain in the surgical area 6 to 12 months after their surgery. And there's a huge range, as you can see. But what you can also see is that the numbers are quite large. And for example, the sort of median or mean for thoracotomy, for example, is 50% having pain at around 6 months. So it's a big problem, and it can go on for years. The surgery itself, it can be very much procedure specific, is an issue. And so the more minimally invasive we can get, and we heard about Roger doing the first robotic case at the clinic, the more confined and the less tissue damage, the less nerve disruption, etc., the better. So, for example, open hernias, you get more long-term pain than with laparoscopic hernia repairs. Admittedly not cancer surgery, but the principle that counts. And there's data. It can be that you develop long-term pain more commonly after suffering more intense pain initially, but we don't know if that is a causative effect. It may just be related in the sense the same causes causing bad pain throughout the whole patient experience. But we could try and do better at managing that intense pain initially. And of course, if there's adjuvant or coincidental, obviously in these patients, use of chemotherapy or radiotherapy before or during or after their surgery, if there was pre-existing pain and opioid use, psychological factors are incredibly important. If they're smokers, and younger age. So the younger you are, the more likely you are to get this type of pain, and the longer you may have to live with it. So biological and psychosocial factors. There are, however, 1 or 2 preventative strategies that are proposed. Now, none of these are completely nailed yet, but it'll be fascinating to see, and it's going to report shortly. A huge trial going on in Australia, nearly 5,000 patients in a prospective randomized controlled trial, with ketamine being administered for up to 72 hours from the start of the surgery. And also intravenous lidocaine, lignocaine we used to call it, may also be beneficial in reducing the changes in both the peripheral, but particularly the central nervous system that lead to prolonged pain after surgery. And also, again, this hasn't been shown, it's been shown to reduce pain and it's been shown to reduce opioid use after discharge from hospital. But the concept of the transitional pain clinics, which are essentially pain services that extend beyond the time when the patient is discharged home and continue to, albeit by telemedicine or in liaison with the primary care setup or nurses, etc., in the community are able to help continue, advise and manage those patients in terms of their pain management. We know we can reduce pain and we can reduce opioid usage. As yet, there isn't data to show whether we can reduce chronic pain. So I'd now like to change gear a little bit and move across to some treatment options. And fear not, I'm not going through a textbook of pain management. But suffice it to say that across the board of chronic pain management, it's not an easy path to tread. And as Andrew's already said, there are so many different factors that lead to a patient, and absolutely the inextricable link between mental health and pain. The one leads to the other and the two conspire and so on. So in this group of patients with all their fear of recurrence and effects on their lives and their work, and we see all these even younger people now, not that older folks aren't upset when they obviously have a cancer diagnosis, but you can imagine what it's like if you are a young parent and so on, and the implications. So the treatment options need to cover all of those. And there are some useful starting documents, though there's some deficiencies I'm about to draw attention to. But for example, here in the UK, we have the framework for provision of pain services for adults across the UK, an NHS and Macmillan, etc. supported document. Now, it was interesting in many respects. There was a lot of great stuff in it in terms of healthcare professionals' guidance, dealing with continence issues and all sorts of other major problems that our cancer survivors suffer. Interestingly, there were two harrowing, and I haven't put them up because one of them at least is rather melodramatic, one might say, but clearly heartfelt cry for help. Two patient headline quotes at the two sections in the document. But when you search for the word pain or pain management or neuropathy or whatever, you come up with only, in fact, one brief mention of pain and no mention of neuropathy. So there's still more to be done to draw attention to the needs in terms of pain management that we need to do. So I'm not going to go through all of these. It's just a list of all the sorts of bits and bobs that we can come up with for the treatment of chronic pain in the population, and it is here applied to cancer survivors. But what I'm going to draw attention to are a couple of specifics that I'm going to come back to. For scar pain and the sort of peripheral pains around wounds, and also the glove and stocking pain. Seeing we're talking about cancer survivors, and that's a big issue. The other one is that there is reasonable data for duloxetine as well as other anti-neuropathic pain medicines. And of course, you've not heard me talk about opioids yet, and we need to deal with that. So we're going to look at that in a moment, but before I do, let us just remind ourselves that we need to apply for these cancer survivors with long life expectancy, and many of whom will potentially go on to die of something entirely different in decades' time. We need to manage them in the same way as we'd manage all our other chronic pain patients, the non-cancer chronic pain patients. So the risk-benefit profile has to be appropriate for long-term therapy. Not for an acute therapy, and the evidence base has to be there for long-term therapy. So all of the things that we preach to ourselves and we try to adhere to, advising the patients on and educating them on self-management, supportive care, the non-pharmacological methods that can be useful, procedural methods, interventions and so on, appropriate pharmacological options, and of course coupled with other healthcare professionals working as a multidisciplinary team, psychologists, etc., but also physiotherapists, rehabilitative approaches, etc. And what about opioids? Because clearly they play a huge and important role in acute pain, in terms of surgery, for example, in acute cancer management, in palliative care. But what about in the cancer survivors who might live for decades? So the question is to prescribe or not to prescribe. And we heard from Andrew that things are absolutely by no means sorted out yet. And in our minds as clinicians, as healthcare professionals. So in a great centre of excellence in Pittsburgh, they conducted locally a questionnaire of a variety of highly placed specialists, eminent specialists in palliative care, pain management, oncology, internal medicine, to try and understand how they see what they think the correct approaches should be or are, or what's already in place in cancer survivor management. So the first thing to say in relation to opioids is there was absolutely no consensus on opioid prescribing other than they were all concerned about it and not quite sure how to approach it and what was for the best. Participants, this is not the patients, the people being questioned, the experts, they suggested improvements along the lines of developing clear systematic guidance for chronic cancer pain management to facilitate communication between clinicians and other healthcare professionals, create tailored survivorship care plans in partnership with patients. In other words, don't just sort of say, you know, the scan looked fine this time, see you again in 6 months, but actually think through what are the patient's needs and goals and so on. All of this, of course, takes resources, or will take resources. And we need to develop accessible, evidence-based, all types of therapy, including complementary therapy. So I was saying that with opioids, we have to have the same approach as in chronic pain patients. So the same concerns regarding the long-term use of opioids, and I'm sure everybody in the room knows all about the appalling opioid epidemic, which sort of started from prescribed opioids, but is now, of course, gone way beyond that, but was fueled by it in the early days of unwarranted levels of opioid prescribing. And Canada have got big problems as well, Australia have problems and so on. And you know, none of our territories are devoid of it, but fortunately in Europe it doesn't seem to be quite so bad. But those same concerns need to play here, both for the individual point of view, because of course in the long-term therapy, opioids, the evidence base for their utility is very poor. They're definitely, there's superb evidence for their use in acute pain, in active cancer, and of course for their use in palliative care. But in long-term chronic pain therapy, they, for some patients, the risk-benefit ratio may be right and it can give them benefit. But we are now much more reticent to embark on giving long-term opioids to non-cancer patients. And it all needs to be very carefully discussed. The American Society of Clinical Oncology, ASCO, in their guideline on the management of pain in cancer survivors, ranks opioids as third-line treatment. So absolutely some way down the list. And I think the most important aspect is, aside from all of the decision-making and careful patient evaluation, is that there must be ordained and adhered to regular review of the opioid therapy and stopping rules if one feels that it's not useful. Now, I'm just going to touch, as we come towards the end of the talk, on one particular type of treatment that is particularly useful and not many people are terribly au fait with. But this is something actually that we've just, so I'm going to bang my drum this time as Andrew did for his research study. We've just introduced a service at the clinic where we are applying capsaicin in the form of this patch, a Qutenza patch, to peripheral neuropathies. So it could be post-hepatic neuralgia, and after all, shingles occurs in cancer patients, but it could be non-cancer, some other peripheral neuropathies, diabetic neuropathy, etc. But on our theme of cancer survivors today, we would be able to offer this to appropriate patients for their glove and stocking chemotherapy-induced peripheral neuropathy, for example. And the mechanism of action is that essentially the capsaicin reversibly desensitizes nociceptors in the skin, and in the cancer field, we'd see that we'd be using it for the CIPN patients and for the post-surgery scar pain patients. It has to be applied by a healthcare professional. It's straightforward, but nevertheless is a procedure that needs to be done in a healthcare setup. You can't send the patients home with these patches to apply it themselves. Each application provides about 12 weeks of pain relief, and of course there's negligible systemic absorption of the chilies, so of the capsaicin, which of course comes from chilies. So, and it is very much for the treatment of pain, and of course it can be used instead of and actually substitute for the systemic anti-neuropathic pain medicines, which are not always successful in managing the pain and of course have significant side effects. So just to say, it's not only the kitchens now in the clinic that are providing chilies to our patients, but we are as well. So summing up, a few key messages. One could have drawn on a lot of things, but I think obviously the triumph of greatly improved cancer treatments and outcomes with ever more cancer survivors is marvellous, but it presents new challenges. The responsibility of optimizing their functioning and their quality of life is upon us as healthcare professionals. And as you've seen, there's a whole spectrum from education to highly sophisticated interventions that could be applied and individualized for our patients' needs. We need to know what their goals are as well when we're discussing with them what they need and what their concerns are. Essentially, and I think Andrew's already covered this already, but cancer survivors do not yet have an established home in healthcare, and they're potentially falling between stools. They present at all different doors. It's just like, well, a lot of our chronic pain patients actually. They turn up at all different access points in the healthcare setup, and it can take years before they get to see somebody who actually might have an answer for their particular needs. And as we've heard from Andrew, take his analogy, if you go into Tesco's or Waitrose, but you need to know which aisle you need to be going down. And that might need a healthcare professional to guide them, because they may not know that they need to see a neurogastroenterologist for their visceral pain, for example, or a neurologist or pain doctor for their neuropathy or whatever. All they know is their skin hurts or it's very sensitive and they can't wear shoes anymore, or it's painful even walking to the bathroom. So they haven't got a home. There's unmet need remaining regarding the recognition and management of specific sequelae of cancer and the treatments of the cancer. And what we need to do is to ensure that some of the common pain outcomes of having cancer treatments, such as chronic post-surgical pain and painful chemotherapy-induced peripheral neuropathy, that those conditions are more widely recognized, and that the patients are directed to the right specialists to try and help with their problems. And that, of course, will require education, appropriate guidelines, referral pathways, specialist care as necessary, as Andrew's already said, and above and beyond all, a recognition by those that hold the purse strings that we will need to fund these resources in just the same way as when new developments have occurred or new needs have arisen in the past. We need to be responsive. Thank you very much for your attention. Yeah.
Great. Thanks so much, Richard. Okay, we'll move on now. Greg Shields, psychiatrist from King's, is going to introduce his two other guests, and we'll have a panel discussion. Then we'll get Richard and Andrew back on the stage again. Ron.
Good evening. Thank you very much for having me. I am a psychiatrist. I do work at King's and at the London Clinic as well. My specialty area is oncology, and I previously worked in haematology. Today, you're not going to hear me talk all that much. I've invited my backing dancers here. So I'm going to introduce Alison Hancock, who is both from a volunteer at Maggie's and expert by experience and a cancer survivor herself, and Troy Chase, clinical psychologist, again from Maggie's, who've kindly offered to join me here today for a conversation. So will you guys please come up and take a seat? I'm going to go through some very, very brief slides. And can I ask someone, whoever is keeping an eye on time, to give us a time check in case we get to him? Give us a 3-minute time check, maybe. So we've talked a lot about various aspects of the cancer journey, and I just want to emphasize that the psychosocial impacts, and talking both about the positive and the negative impacts of having cancer, are different at different stages of the journey. Different themes emerge at different parts of the journey, and there are often common themes that we can see in groups of people, for example, after diagnosis, after remission, well into the future, post-treatment, post-cure. That we see these common themes emerge, and they're the sorts of things that I'd like to have a bit of a conversation about today. I'm not going to go through the slides about unmet needs because we've talked a lot about those already today. What I am going to do is to introduce, this is the Managing Cancer and Living Meaningfully, or CALM psychotherapy framework for treating or for addressing psychosocial needs of people with advanced or metastatic cancer. And I introduce this only because I think the 4 domains that are the key pillars of CALM therapy are really helpful in these sorts of conversations, and for us as clinicians, for those of you who are clinicians, including myself, to think about what are the different ways in which cancer might impact people at these different stages. And so I'm going to leave this slide up just thinking about how symptom management, the things that we've already talked about today, is so crucial. Communication with healthcare providers and relationship with your healthcare team has such a significant impact, negative or positive. How we change ourselves in relation to our own identity and roles, but also in relation to other people around us. Things like spirituality with a big S or a small s, religion, or other things that give us a sense of meaning and purpose in our lives. And thinking about the future, how do we sustain hope, and how do we discuss mortality when our life is at threat? So with those themes in mind, I'm not going to show you any more slides. I'm going to perhaps start, I'm going to take a seat and then ask Alison, maybe in the first instance, to respond.
Yeah, I was diagnosed with ovarian cancer 2 years ago. And that came as a bolt out of the blue because I was a very healthy individual up until that point. 35-year career with John Lewis, always healthy, never off sick, etc. And I was referred to the Royal Marsden and went through extensive surgery to remove the cancer and went through 6 rounds of chemotherapy, which kind of took the rest of that year. I then went for routine breast screening in January 2023 and was diagnosed with breast cancer. So was back in the Marsden for another stint of surgery and then had some radiotherapy. And I think the one thing I would really like to get across to somebody that's actually been through this is I believe cancer, now that I've had it twice in quick succession, is as much the mental battle as it is the physical battle. And I think certainly from my experience of the Marsden, what they excelled at was identifying quickly what was wrong with me, telling me that I needed to have surgery, that it was risky, that I might not survive the op, etc. That once I was through the op, assuming I got through it, what the prognosis was likely to be, and they were absolutely spot on with all of that. So from somebody that had done a career where certainty was a big part of my life, I felt very certain in the clinical diagnosis from the Marsden. And when I went back for the breast cancer, it was a similar experience. But the psychological impact of having 2 cancers in quick succession was identified by my surgeon at the Royal Marsden. She recommended I should have some psychological therapy. And at the point where I was being offered that, there was effectively about a year's wait for that to happen. And again, the message I want to really get across tonight is, rather than that being perceived as a negative message, i.e. we don't have the resources, we haven't got the people, etc., what I have found huge inspiration in was one person at the Marsden who verbally said to me, have you thought about going to a charity? And at that point, I never had. And so for me, the transformation in how I am viewing my cancer was being referred to Maggie's. And to say I've become slightly evangelical about Maggie's would probably be an understatement, but I do that for the very positive reason that a very negative message that was given to me by various consultants, to be fair, which was, we're really sorry, you know, it's going to be months and months before we can give you any help. Within a matter of weeks of meeting Troy, I was having psychological therapy. And I described that quite openly as life-changing and life-affirming for me. So in summary, I think it's about how do clinicians who are absolutely expert on the technical side of cancer and the need to put you right, they need to also bearing in mind there's this massive psychological battle of all the things that have been mentioned already. Am I going to die? When am I going to die? Etc. And all I would say is it's not just Maggie's. There are many, many other charities out there who are doing great work. And it's twisting that conversation, turning it from a very negative message, which is we're going to struggle to help you, to have you thought about other options? And it isn't just therapy either, because for some people I do a lot of walking, and we've talked about that. So there's lots of other ways that people can turn the psychological effect round. And I certainly feel the benefit from having engaged with the charity, and all that's for free. So I'm walking into sessions with Troy, and the beauty of Maggie's for me is, for anybody that's been to a Maggie's, is it's a completely different environment to an NHS setting. And actually, I'm deeply grateful in a way that I was put off by the NHS, because I've now discovered a charity that I can involve myself with. I'm now doing a lot of giving back. I'm volunteering for Maggie's. And that's given me a whole new purpose, which again, 2 cancers down, I feel frankly proud of, but also I'm really enjoying that interaction with such an inspired charity. If that makes sense.
Thank you. I mean, there's so much in there, and I was just thinking about one of the slides we saw a few minutes ago that were talking about a tailored, bespoke, collaborative, comprehensive treatment plan, and how it sounds like a lot of the things that you experienced met that need, although
Yes.
not necessarily immediately.
Yeah.
And I want to touch on something that you brought up right at the beginning, and that was the thing about certainty and how helpful it was for you to have certainty. But I think we had a conversation about this earlier as before we came in, about how uncertainty is such a common theme in cancer care. And I wonder, Troy, if you can speak to that, because I think it's something that people really do struggle with a lot.
Yeah, I think what we see, and I'm grateful for Alison for joining us. Don't expect you to blow the trumpet as loudly for Maggie's as you do, but always grateful, so thank you. I think what we get used to as human beings is the certainty of waking up and knowing what our day is going to be like. I think then what we notice then with people who are diagnosed with cancer or any major illness actually is it really brings into question about your ability to predict a number of things, your ability to predict how your day is going to go, how long life is going to be, what your quality of life is going to be. And we then know that what tends to happen with people after they've been diagnosed and sometimes successfully treated for cancer is that there is a real loss of certainty about the future. People will spend a lot of time thinking about cancer recurrence. They will spend a lot of time looking at their bodies to figure out if something is wrong. They become very uncertain about a number of other things like their finances. Their relationship is also sometimes in question. And sometimes, because people can experience things like chemo brain or what we call cognitive effects following treatments for cancer, people can also wonder about their ability to return to work and to be able to do that with any certainty at all. And undoubtedly, what people are most concerned about is the risk of recurrence and what that will mean for them and for their families.
Thank you. I was just thinking about the dynamic between a clinician, between the patient and the patient's families, and how that wish to have some certainty is often something that's taken to the clinician in one way or another, not usually explicitly, although sometimes explicitly, and how that might affect the relationship between the healthcare provider and the patient. Usually when a patient's looking for certainty and a healthcare provider is not able to give that, or is not able to handle even sometimes that conversation around it. I wonder, I don't know if Alison, you could speak to that about your relationship with your healthcare providers, and maybe Troy also about your experience with other patients as well.
Yeah, I think For me, the surgeon at the Royal Marsden that I was under, or still am under, I think typifies for me the certainty that you need in what you're going through. So when I first met the surgeon, she absolutely didn't pull any punches, that it was a big cancer, it was a rare cancer, etc. But as hard as it was to sit through a sort of hour consultation with her, hearing exactly what she was going to do to me when she put me to sleep, what it did give me was certainty that I knew exactly what was coming. And it sounds a bit bizarre maybe, but because she was so straightforward with me and was very certain about what she needed to do in order to try to cure me, it actually made the surgery a lot easier. And I should give you the background, which is up until the age of 60, when I was diagnosed, I had had really very little hospital intervention in my life. Never had children, never had need really to go into hospital. So going into the Marsden for that major surgery was my first intervention. And it was the common touch. You know, she came to see me, which I know is common, that's what happens, but the way that she came across to me gave me full confidence that her and her team knew what they were doing. She didn't use jargon, she didn't patronise me, she just treated me like a human being. And I think I then totally trusted her. And I'm proud really to say that I came through surgery well, and I came through it with very little pain management. Actually, I managed to be discharged on just paracetamol, because I believed very strongly that what they'd done was they'd fixed me, and therefore my mental thing was actually more important to me. But I think, you know, lack of jargon is so important, or if you're using jargon, making sure you're explaining it, because too often as cancer patients we have to Google what's in letters, we have to Google the conversation, and when you Google you go to worst case, which then just freaks you even more. Whereas if a surgeon, as she did with me, said, you know, I might find something else, you may wake up with a colostomy bag, you may wake up with a stoma. The fact that I didn't wake up with either of those things was a massive relief. And in fact, I think if anything, she was almost saying to me, you know, you are seriously ill, because I was almost jubilant after the operation thinking, you know, I got through this. But that was because she had been so straightforward with me. And I think that is so, so important, that at the end of the day, you're all, you know, incredibly powerful people, but to us as a patient, we look to you. And I think the more human you can be with us, and the more you treat us as humans, that has to be a really good recipe for the patient. Because certainly for me, trusting her and being clear on what to expect was a massive part of my recovery. So I don't know whether you want to.
I think there's something really profound. Sorry, I just wanted to respond to that quickly. I think there's something really, quite a profound message in there, in that the nature of your relationship with the healthcare professional in itself almost has physical benefits to you. It's almost dictated your experience of the cancer in itself. And I think that's where the mind-body thing is so inextricable. And I think we underestimate that so much. And I was also thinking, and maybe Troy, maybe you could respond to this, but how different people do have different information preferences, and the impact of being given information in the way that you prefer it at the stage of life/cancer that you're in, and how that is different between different people. I don't know if that's something that...
Yeah, so it varies, of course. I think what we know is that some people will benefit from having a lot of information, as some people only really want to know as much as they absolutely need to know. I think what really helps, and so Alison alluded to this, is the real benefit, though, in terms of knowing your patient. Trying to understand their needs, trying to understand what would be helpful to them. Alison also made the point that our patients are humans first, and so I think it's being able to see them as that, to being able to establish a relationship, ask them what they think would be valuable, and then providing it in a really paced way. I think what the research seems to suggest, and which makes a lot of sense, is that if nothing else, people hate being overwhelmed with information. So even if you are going to be the person that values a lot of information, you really value from being drip-fed that information, not using a lot of jargon, and also being able to be accessible. I think we know then that the relationship with an oncologist or palliative care consultant or psychologist is one then that will probably be there for a while, so that need maybe to answer all of the questions all on one occasion is really not there. What we can do is pace and give information to people in a really slow, helpful manner, allowing them as well to ask questions, not seeing it as a didactic exercise, but more a collaborative discussion.
I spoke to someone recently who told me that they'd had 3 people in the room talking to them for 45 minutes to an hour at a time, just after diagnosis, while they were in the hospital, and how overwhelming it was. And also, I think, just recognizing how impossible it is to take in any information at that point. And I think, again, we're talking about how these early interactions, where there is so much information coming in and so much change, and so much anxiety, that those early interactions at those times can really dictate whether someone feels contained and reassured and trusts the healthcare provider. And I use that term very, very broadly. It could be doctors, nurses, allied health, or how it sets up an anxiety. And we're quite, in the end, we're complex beings as human beings, but we're also quite Pavlovian. And if our early experiences are of anxiety, overwhelm, those are what we think of when we go in and see the doctor. That's what we go in when we go into the hospital. And so actually, I think as clinicians, we can be aware of that and be aware of that everyone's individual needs and work with the person in the moment. What can you handle at the moment? And I think those sorts of conversations really early on are so important.
Oh, totally. It is also the recognition, though, that when we're particularly anxious, that the brain doesn't function like it normally would.
Yeah.
And so you might expect then, and I think that that's why we also encourage patients to give themselves permission to feel a bit challenged, because people will think, oh gosh, I've been a businessman, I've been able to excel so well in my career, or I've been able to do this, I did really well at university. Why is it then that I'm going to these medical appointments and then getting dry mouth, getting really anxious, can't hear, can't ask questions? I think it's that ability to say that you are now in a position where your life is feeling threatened, and you're probably feeling vulnerable for one of the first times in your life, and so the brain is going to respond in a very different way. It means then that the ability then to come back to another appointment with questions, not just being able to move very quickly on the spot, is there.
So having that space is so important. And I wonder, Alison, we've got 3 more minutes. Is there anything you'd like to say in sort of response to that?
I think what I would say actually is, I don't think it doesn't have to be psychological therapy that helps somebody with cancer. There are lots and lots of other things that can help. We were talking to somebody just before the session actually, and dancing can help, gardening can help, walking can help. There are so many different things, but I think it's about, for me as somebody that's living through it, it's, as I said earlier, it's about the clinical team connecting with the psychological side of what you're going through. So not just dealing with the clinical side, but actually acknowledging that as a human being, you are going to be scared at times, you are going to be terrified at times, frankly, you're going to be over emotional. I mean, I'm not proud to say that my first meeting with my surgeon, I spent most of it crying, because I think I just couldn't get my head around what she was actually saying, but then deeply grateful, as I said, that she had been as honest as she had. So I think it is that. It's about how do we deal with somebody in a very rounded way. So it's not just, you've got cancer, this is what we need to do to fix it, but there's that other massive bit. And I'd sort of end, I think, with the fact that it's that mental battle. And if anybody in this room can think of that all the time, it's not just, we've just got to rectify this problem for this person. We've also got to help their mind get through this problem as well. And that can be done in a myriad of ways, I believe.
Absolutely, and some of those ways are big, like having therapy or addressing major existential issues. Some of them are really small, as we've heard a lot about today.
Yeah.
Thank you so much to both of you for coming to talk with us today. Thank you, everyone, and we'll finish up and take questions.
Thank you.
Hand over to you, Roger.
We're going to get Richard. Fantastic presentation, Alison. Yeah, very brave of you to come and talk to all these doctors. So we'll have some. Can we have the lights up a little bit? And so we've got some mics on either side. There's a hand I can see over there. Oh yes, this lady always asks a question.
Yes. My question is, I go straight away to the point. How selfish a person that is at the end of their life can be selfish, and the anger that might come over For instance, just quick, I will explain. A person that got generalized cancer, knowing that this person was going to die, was behaving in the way that even expressing, I don't care, I will die, I have to live my life, I will smoke weed, the weed help me, all the time running everybody with her anger, and was quite really impossible to keep going for everyone, professionals and the family. Even the 2 dogs that this person had passed away because of the weed that this person was smoking. And finally, this person died, but the anger was out of the system.
Yes, I think the question is anger, which I mean, Alison, you've got the opposite of anger, but did you ever feel angry that it sort of affected you? Particularly 2 pretty bad luck to get 2 cancers, one after another.
Yeah.
Was anger part of your response?
I think marginally, but I think I was saying to Greg earlier, I think given the career I had, I was very much, I had to do quite forensic stuff with John Lewis because I was managing big projects and things kept going wrong. So I think for me, I've tried to bring second life into my cancer, if you like. So as I sort of alluded to earlier, I'm doing some stuff now with Maggie's, which is giving me hope, is giving me reason, and is making the sense of the nonsensical. That's how I describe my sort of anger is more, I don't think I've ever, I said this to Troy, I don't think I've ever actually said, why me? Why have I got cancer? Because frankly, every time I have an intervention at the Marsden, I'm humbled by people who are younger than me, who have got so much more going on. Somebody alluded earlier, they've got families, they've got children, you know, they're going through breast cancer with young, I mean, I'm just in awe of people, to be honest. So I think I'm trying to channel if there is anger in there, into doing stuff to help others, if that makes sense. That's been my way of trying to deal with this, rather than inwardly kind of going, why me? I'm trying desperately not to do that while I'm well.
Andrew, you must have faced angry patients. In Dublin, people get angry sometimes.
Yeah, and not just because they're my patients, but I think there's a couple of things I'd say, is that people's personality doesn't change when they get cancer. Okay, so sometimes angry people are just angry people. And you know, just because you got cancer doesn't turn you into a nice person. So I think what's really important is to understand whether this is a normal reaction, whether this is the way this person has reacted all their life, or actually is this a sign that they have got some, you know, some psychological issues that really need addressing. So I think, you know, trying to get to know them, get to know their families, what they're normally like. And yeah, I mean, you have to put yourself in their situation. Like, you know, if it was me, yeah, you know, I would probably be angry and frustrated, and, you know, particularly for most of the patients I see at the moment. So most of my clinical work mainly at the moment is in the hospice. And we do have patients that come in with symptom control and go home, but most of the patients are end-of-life care. And, you know, we have patients in their 20s. Not very often. We have patients in their 30s, okay, who visit, you know, their young kids come in to visit. They're never going to see their kids go to school or graduate or whatever. And yes, of course they're going to be upset and they're, you know, angry and frustrated and all the other emotions that you see. And it's just about recognizing that as a normal reaction, but also recognizing when they need specialist help. Yeah. You know, people are not supposed to be happy when bad things happen to them. Yeah.
There's a story in the paper of a 24-year-old girl with breast cancer who started that charity and died aged 34. Any questions from the audience? Or have we got any cancer sufferers in the audience, or a question? The microphone there, and then, sir.
Oh, just a comment about the second point on your slide.
Yeah.
It says changes in self and relations with close others. Instead of changes, I would say strengthen your own personality, or whatever your relationship being with yourself and with others. So strengthen the relationship, and then try and work out. Maybe the person did not have chance to reflect on these things, but that's the time to reflect. Well, what are the positive things within himself, and what been the positive things in relationship with others? And then make best use of that relationship with self and others.
Yeah, that's good. Alison, maybe back to you. You seem to have gained strength from your problems, and now you're passing that strength on to others. So,
yeah, I definitely. I mean, I think it's a really good point that you're making, actually, which is that people view you differently to a certain extent. And I think I've been open with what's been going on with me, because going through chemotherapy, with all due respect, I mean, if I'd been sitting here this time a year ago, I wouldn't have had a hair on my head. So, you know, it's difficult to not tell people when you're going through that sort of treatment. But I think what I found is the strength I've gained from my friends and the strength they've given me. And I think also, in some cases, there are now friends who are going through what I've been through, so I can then be there for them. So I think you're absolutely right. There is a massive relationship thing here where you're reevaluating all the time. And I must just make mention, I mean, for me, my sister has been my absolute rock. And that relationship is, I mean, it's always been incredible, but now it's just off the scale because she has so been there for me. And
so maybe she's
in
got
real
some strength
time,
herself. From
exactly.
That,
but in real time, I'm appreciating her, if that makes sense, rather than sort of after the event.
Yeah. You got peripheral neuropathy from your chemo?
I have.
You should try his capsaicin.
I need your peppers. Chilies. Chilies, not peppers.
Red hot chili peppers.
Yeah,
there's a band called that, isn't there?
But can I just make a point as well? That, I mean, you know, the families, you know, also can suffer hugely, particularly from psychological, but not just psychological, social aspects as well. You know, having to attend appointments, missing work, etc., etc. And often, you know, you see, you know, the spouses trying to keep, you know, a brave face, you know, smiley face, pretending everything is all right, when actually they have as many psychological problems as the patient. And so it's really important to think of, you know, the patient not just in isolation, but, you know, the people around them, their families, their friends, there's you know, whatever their close-knit group of people are.
That's a good point. I was talking yesterday about suicide, and somebody was saying that if somebody commits suicide, maybe because of a cancer diagnosis, there are 130, on average, 135 people are affected by that one suicide. That's something psychiatrists would know more than me. Sir, with the microphone.
I was very inspired, Alison, by your story. I think you mentioned that as well as Maggie's, there are, of course, other charities concerned with cancer. Perhaps I could just say that as a hypnotherapist, I've been seeing people with cancer and cancer carers at Paul's Cancer Support Centre, but unfortunately it closed last November due to lack of funding. And when I think of the inspiration I got from all the people I saw there that I could help, I just wish that more charities were available, because I think there's a lot that can be done.
Yeah, a good point. I mean, funding is an issue we were talking about outside. I think, Andrew, you said that only 37% of palliative care outfits are supported by NHS. The rest is charity. Is that right?
Yeah, and that's in the UK. So there are hospices that are shutting in the UK because they can't afford to stay open. I mean, you know, in the south of England, we're in a relatively affluent area, and, you know, the hospice is, you know, it's relatively straightforward to raise the amount of money, but in, you know, parts of the north of England, particularly in the more rural areas, it's almost impossible to make up 2/3 of your budget from voluntary donations when you're in a deprived area, you know, when, you know, there's a high levels of unemployment here. So that, you know, probably once every 3 or 4 months, a hospice or specialist palliative care unit is closing. And they're charities. You know, there are very few NHS-funded specialist palliative care units. So even for people with advanced disease, you know, the situation has got worse. And that's even before you start trying to develop services for, you know, long-term cancer survivors. I think one of the problems about survivorship is that, you know, there was this attitude, well, okay, they're cured, you know, so, you know, they should be grateful that they're cured, you know, and actually nobody was following up these people. Nobody identified that they were having all of these problems. You know, it was sort of like the iceberg phenomenon. You know, there was this hidden problem.
Are you a different person, Alison, now after your cancer? You seem so positive about it. Would you?
Yeah, I think I am different. I think I view life differently because I can sort of, I call it slightly, which sounds a bit depressing, sorry to sort of end on this, but a bit like looking down the barrel of a gun, you know, because I think for the first time, as I described, I had lived a very healthy life. And I think I'd only been on probably the whole of my life 6 antibiotics or something crazy. So to suddenly then be forced into, with all due respect, the NHS, and forced into many, many clinical waiting rooms and, you know, surgery, etc. I think that has changed me because I think I now can see that I have, you know, I'm human. I'm not somebody that can just keep on going. And so therefore I do now do more to do with exercise, walking, mentally stimulating myself, spending time with people that mean something to me is really important. And that time is very, for me, is very inspiring to be around art or to around theatre or whatever. And that definitely has become more my focus.
Yeah. Richard, you had a comment?
Time with loved ones.
Well, yes, because listening to all of this, I mean, there's one thing I'll challenge you on in a minute, in a gentle way, but I think that, you know, hearing your absolutely inspirational story is obviously a sort of beacon of excellence in the way to deal with what you've had to deal with. Not everybody can manage that.
No.
And so what I was putting in a plea for, in a sense, was that we need the resources, and obviously charity isn't necessarily the most secure way of finding the resources, but we need the resources to look after the folks that are less able to cope.
Yeah.
And so your comment, which I entirely agree with, that people don't change their personalities just because they get a diagnosis or whatever, actually that's true, and some people start with better or worse coping mechanisms. Mm-hmm. And I've seen that in as prosaic an area as, say, the trainees I've managed who've had their problems. Some of them coped well with things, some didn't. You see it with patients, you see it with the family members. So there's the coping. There is illness behaviour, which in chronic pain we see, and some folks respond well, and, you know, as I say, you're a beacon. Other people don't. And they can actually, well, in chronic pain, they can even use their illness, not necessarily consciously, but they develop an illness behaviour, and everybody around them will do things for them, and so they actually do even less. But the thing I would just challenge a little bit is, and you talked about sleep deprivation or abnormal sleep, and in my world of pain, which of course is linked with sleep as well, don't you think that sleep deprivation, pain, etc., can alter the way people behave? Yeah. And when you manage them, they then go back to you know, the personalities that they were, rather than the sort of disinhibited folk who can actually be quite angry or difficult, which I don't mean unkindly, but just it can be quite difficult to relate to people if they are not reaching out to us as professionals.
Hang on, we've got one question from the audience, because otherwise the panel start asking each other questions, and they're not allowed to do that.
I don't see anything wrong.
Yeah.
I've only got one hand that works.
Right.
Hello, I'm from Manchester.
Oh, yeah. Good football teams up there.
I'm halfway, well, I'm 1/3 of the way now from Land's End to John O'Groats.
Right.
I'm going to arrive at John O'Groats on Sunday, the 12th of May, because that is my late mother's 100th birthday.
Right.
And I was the main carer for my late mother when my dad died suddenly from a heart problem in 2019.
Right.
To when she died in 2018. 20 years. So,
right. Question?
A question. And just stay what I'm here for.
Oh, right.
I'm here to get my card stamped.
Right.
For the Land's End to John O'Groats.
Right. And you're raising money for something?
Yeah, prostate cancer. Got stage 4.
All right. Yeah.
In
right.
November, I had a total surprise oncologist diagnosis of stage 4 prostate cancer, which had already metastasized onto my spine, and I since found out that I had spinal cord compression as well, That was in the 6th of November. And here I am on the way from Land's End to John O'Groats.
Well, congratulate. I think we have a round of applause.
Previous problem, which is a brain abscess of the thalamus.
Got it.
And so the prostate cancer problem is a minor inconvenience after what I
Terribly brave. I actually had lunch with the chairman of Prostate Cancer UK. They raise 40 million a year, Prostate Cancer UK now. And what Alison said about how important charity is in this whole area of cancer. I mean, billions of pounds are raised, but for fantastic results. Thank you. I think we better finish now because we're already 10 minutes late. There are drinks outside, so we can continue the conversation out there. So thank you to the London Clinic. Thank you to all the speakers. Thank you, Alison, for telling your story. Inspirational is the word. And thank you all the audience and the people online too. Sorry you couldn't get here, but